So good evening, everybody. My name is Hemant Malhotra. I'm a professor of medical oncology at the Shri Ram Cancer Center at the Mahatma Gandhi Medical College Hospital in Jaipur in India. And I'm going to be your host today. And my most sincere thanks to you for sparing this time with us. And I'm 100% sure that you will be a lot wiser with CML management and treatment by the time we finish in about an hour or an hour and a half. I'm a CML physician, very keen in treating CMLs, and we have a very large number of patients in my country. I'm also one of the directors of the ICMLF, International CML Foundation. I'm sure you must have heard of the ICMLF. Just to introduce it to you, Professor John Goldman and Professor Tim Hughes set up this International CML Foundation. And the main goal of the foundation is to raise the bar of CML management through CML education the world over. And there are a lot of things which the ICMLF does. Clinical preceptorships, a website with a lot of material, lots of presentations, and a real-time, facility where you can post your difficult cases and get answers for your CML problems and your CML patients by world leaders in CML. So that is something which is really fantastic. If you have a complicated case, you have two minds about what to do, just post it on the ICMLF website. Within 24 hours, you'll get a solution to your problem. One of the important activities which we've started a few years back are these regional discussion groups. And today, so in addition to education and knowledge, there are a lot of other things which the ICMLF does. It harnesses the power of global research. And just to give you a snapshot that these are the various things which are very much in progress just now. There is a CML Genomic Alliance. There is a treatment-free DFR Alliance. We have some significant amount of activity happening on the pediatric CML front, particularly in the low-middle income countries. We have a CML hepatitis B survey, and many more things are happening, which you can read if you go to the CMLF website. So, and I did mention to you that we have these very popular regional discussion groups. Today, the Southeast Asia Regional Discussion Group is going to present the two topics. The format which we follow is one regional expert makes a presentation of interesting cases, and then an international expert, gives his or her opinion on those cases, and then we open the cases to discussions by the participating audience, and we hope to do that, do exactly the same. And these are the two topics which we have chosen for our regional discussion today. The first is the choice of tyrosine kinase inhibitor in newly diagnosed CML patients. This is a really burning issue, which all of you would agree with me. If you get a patient tomorrow, you have a newly diagnosed CML CP patient, which TKI would be the best for that patient? So we will have case presentations, and then we will have an expert discussion, and then we will open it to the public, open it to all of you to ask your question. The second topic which we are going to do today is post-CML progression or post-CML no response, no molecular response after 2 or more than 2 lines of treatment. How should you approach that patient? So I think these are two brilliantly selected, very relevant topics which should be of interest to all of you. So let's quickly get on to the choice of our first topic today, the choice of TKI in newly diagnosed CML patients. And these are our two presenters today. Dr. Mipsang Lama is from Lalitpur in Nepal at the Patan Hospital. He's a clinical hematologist and a bone marrow transplant expert. So he's going to be presenting two cases back to back. And our international expert today is Professor Gianantonio Rosti. He is at Meldola in Italy, and he is one of the world's acclaimed CML experts. He's visited India many times, and he's a very dear friend. So welcome to both of you, Dr. Lama and Dr. Rosti. And now I hand over proceedings to Dr. Lama so that he can, kind of share his slides and take us into the first case.
Thank you. Good evening, good morning, good afternoon. We are all over the world, so I should be saying this. So topic for me was the choice of TKI in a newly diagnosed patient. So next slide, sir. So if you look at the NCCN guidelines, chronic phase CML, we do a risk stratification with a so-called scoring or UTOS scoring. And then if it comes out to be a kind of a low risk, then we start with the first generation imatinib. If second generations are the choice, like dasatinib, nilotinib, or bosutinib. And then there is a new introduction of allosteric TKI, the STEAM inhibitor, asciminib, as an upfront for that is a choice. If it happens to be an intermediate risk, then probably we should be starting straight from the second generation TKI. That's what they say. Like there is no preference, but then depending upon the patient's clinical condition, comorbidities, we choose the right TKI for that. And also, yeah, you could use the new drug, the asciminib, as a first line for the like intermediate or high risk patient. Next, sir. Now, next slide. Okay, thank you. So I would like to begin with my first case. Mr. BR, 31 years male, initially presented to Saudi Hospital on 8th November 2024 with left upper quadrant abdominal pain. What discharge summary says is the total count is 121,000, but then no other parameters were given. USC, we could see a moderate splenomegaly with 21 centimeters with focal lesion, 4.5 into 5 centimeter, showing poorly demarcated hypoic areas with turbid content and no internal vascularization. The management done at that hospital was hydroxyurea 500 TDS for 3 days, then 1 gram BD for 7 days. So bone marrow perform shows a CML. However, reports were not available. We could see that like they have started an asciminib 40 mg twice daily on 10th October 2024. Next. On 6th of November 2024, the patient revisited with a recurring left upper abdominal pain again. So repeat USC was done, enlarged hypoechoic splenic lesions, 12.5 into 9.5 centimeters with internal vascularization, likely splenic infarct. It looks like nothing was done at that point of time. And then on 10th November, he arrives in our hospital. We performed a CT scan, and CT scan showed it is a splenic abscess. So pictal drainage was performed, and the culture shows the Citrobacter frurendae, which was sensitive to piperacillin and tazobactam. We perform a bone marrow. Bone marrow was karyotyping was a normal karyotyping. FISH for BCR-ABL was negative, but unfortunately, PCR for BCR-ABL was 5.31% at that point of time. Next slide, sir. So my question to Professor Rosti, any urgency to start a hydroxyurea in this case? How common is the splenic abscess in a CML patient? How do we do a risk stratification in case of splenic abscess? And the role of asciminib upfront treatment and added advantage over the usual TKI that we do, imatinib, dasatinib, or nilotinib. Over to you, sir.
Okay. As far as IDRIA, there is no urgency, and generally, whenever it's possible, it's better to start with the TKI soon. I start with IDRIA only in case of very high platelets count, for example, or a painful big enlarged spleen, but it is 5% of cases, probably less. splenic access in CML is a very infrequent observation, still in my experience and looking at the literature. So you are a very uncommon obstacle on the track of your patient. And then I noticed that he had already apparently a very good response, a normal karyotype, only 1 month after starting asciminib, and so it is a very, I mean, should be published as a case report because it is an interesting one. Asciminib upfront, I mean, very shortly. The only problem of asciminib is probably the added cost of the treatment. But if we forget for a while the cost of the treatment, asciminib is far the drug wonderfully tolerated by most of, at least of my patients, and the literature is saying the same thing up front and in third or fourth line. So asciminib, probably one of the potential problem of asciminib when using monotherapy is the emergence of mutation, and will be discussed probably later, discussing about a third line patient. I mean, mutation unsensitive to asciminib, but starting a naive patient upfront with asciminib is a very good choice because safety is very good. Now we have data in the long term, 7 years of the phase 1, but many other trials using asciminib are beyond 3 or 4 years. So, and the quality of life, I'm treating personally roughly 25 patients with asciminib, is absolutely wonderful. And the potential in the long term, not yet the data generated, but the potential advantage in the long term is the increasing year by year number of patients reaching a condition good to think to a TFR figure. So it's a very important drug, and as soon as it will be available, even in my countries, currently is available in US and probably in Saudi, as you said me, Mipsang, I believe that it will be used largely. The only problem is the additional cost, but any improvement of our treatment armamentarium is even linked to an increase of numbers. But this, I mean, this is normal when proceeding along the track to have all the patients with CML with a good quality of life and with a good response. So my very positive perception of asciminib upfront.
Thank you, sir.
I'd love to chime in if that's okay. I haven't been introduced, but I'm Kendra Sweet from Moffitt Cancer Center in Florida, and I'm supposed to be doing the next slide, but I just wanted to kind of echo some of that. As far as the splenic abscess, I actually have never seen that, so that's really interesting, and it certainly does complicate risk scores because of the impact on splenomegaly and whatnot. But I've never experienced that, so that's really fascinating. With regard to asciminib up front, I completely agree with Dr. Rosti that the biggest downside, if you will, is the cost, which now we have 2 generic TKIs. We have a first and second generation drug that are generic and both work incredibly well. And so I think that becomes an even bigger issue. When the question previously was generic imatinib versus a second generation, but spending more money on the second generation, you could argue, I think, a little more strongly for, you know, the benefit of the extra cost by providing a second gen TKI up front. In this setting, I don't know, but I will say that I have to completely agree that the tolerability of asciminib is really outstanding. And if you're looking at a young patient that you're going to, hopefully get off treatment someday, but if not, at least someone that's going to be on treatment for a long time, that is huge. And I probably also have 20-25 patients on asciminib right now, and none of them complain. It's fascinating. And most of mine have been on other drugs prior to asciminib, and the difference in their in the side effect profile is really astounding. So I really think that that's the biggest advantage. Right now, you have some people who say if you start asciminib, you shouldn't plan on attempting to stop. I don't personally agree with that opinion. I think that if you can establish a deep molecular response, then I don't know that it really matters which drug got you there. And I imagine that, as more data becomes available, that will probably become more of a common opinion. So I think that the plan for TFR is a reasonable one if you're starting someone on asciminib, and likely we'll get more people there with a more potent drug.
Yeah, so my
Just
two
a
bit
quick
on
question
this, my two bit on
Okay,
this,
sir.
I think for all patients who have a total count of more than 100,000, I always start hydroxyurea along with the TKI. And unless this patient is very septic and toxic and unable to tolerate first or a second generation TKI, in that situation, asciminib might be or will be a better tolerated drug. And once the abscess is taken care of, once the infection is under control, rather than the patient spend all his savings on asciminib, I would be more than happy to shift him back to a second generation TKI.
Okay, sir. Yeah, can we move? Okay, so just continue with the case. So diagnosis of CML remained doubtful at that point of time. So we continue with the pictal drainage, and antibiotics continued till 6 weeks, and removed after collection was less than 10 ml. I did an expert consult with Professor Savio. Dr. Rosti must be knowing him. So we just advised to plan to wait and watch for 3 months, and then work up at that point of time as a new one. So the patient was discharged after the splenic abscess was resolved at the mid of December 2024. Next slide, sir. So after 3 months, 23rd Jan 2025, we repeated everything, and everything came out to be fish per PCR level positive, RT-PCR is positive, quantitative is 45.213%, karyotyping showed now the translocation of 922. Next, sir. So at this, Professor Rosti, so should we restart on asciminib, or how do we explain the disparity of these reports?
My frank answer to question one is sure, if available, restarting asciminib, because it was on asciminib but no more than 20 days before interrupting it for the splenic abscess. Yes, I cannot explain the disparity of the reports if not with a mistake of the previous one you reported. Your new workup was clearly and logically adherent to a sequence of events in a CML patient diagnosed before. So it's not reliable what they reported before. A mistake. Yeah.
So I have another kind of explanation for this. Dr. Lama, how long was the patient on asciminib before he came to you? Did he have adequate exposure to asciminib, say, for a month or a month and a half?
26
it was
days.
about yes.
So how many days? Sorry?
Hardly a month, less than a month, 25 to 26 days.
So like a small number of patients do have a quick response to the specific BCR-able agent. So I think maybe, Tony, would you want to consider that he responded to asciminib, his BCR-ABL went down and he went into a cytogenetic response. That's why his pH was negative. And then when we stopped the anti-BCR-ABL treatment, in 2 or 3 months' time, the CML kind of, so to say, relapsed.
So, after less than 1 month of asciminib, to have already a complete cytogenetic response is honestly is too much. At least it's highly unexpected. But because in 4 weeks of even the most potent TKI available are not enough to promote a complete change of hematopoiesis from a leukemic one to a normal one. It's my perception then. So why I said it's probably a mistake.
What happened with the guy's white blood cell count? Did it normalize in that first month and then it increased again in the 3 months that he was off? Like, I'm just curious how that correlates with the rise and fall of that the BCR-ABL in the cytogenetics. Do we know, is his white count normal when he had did his white count normalize, I guess, within the first couple of weeks, which would be normal?
Yeah, the counts kind of stayed normal and it didn't rise. If that was the reason, then we could have thought probably that, because like quantitative PCR was 5 point, but since count stayed on the lower side, even though that like he has this abscess, so we just tend to say like, I mean, probably this diagnosis was really doubtful.
Yeah, so I would actually stick to my explanation. I think that this patient had an exceptional response, exceptional quick and deep response to asciminib. If Dr. Mipsang is sure that his lab reports, the first one and the second one are correct, that could be an explanation, I think. So anyway, we need to move on.
Yes.
Over to you, Dr. Mipsang.
Okay, yes, sir. So we continued with imatinib for 26 Jan after this report because he lacked all the documentation and then he report. So we had to start on that as you know that we usually as a protocol. So after like 3 months of imatinib, now his BCR-ABL quantity was 8.8. So if you look at the milestone, since we started imatinib, he's kind of okay. But if we consider from the beginning, then probably he could be in a warning stage. So next slide, please. So Professor Rosti, was the upfront asciminib justified for this patient? Is the response adequate now? And should we switch TKI now or wait for another 3 months to go below 1%?
Of course, asciminib was justified for this patient because now it's licensed for first-line use and things are going on in Europe and other countries and will be available probably here next year. So with the long history already of asciminib as far as response in third and fourth line and front line in a young patient, and I want to underline because in a young patient, tolerability is a very important tool because where lack of adherence is still present, at least in Europe, in our experience in Europe, is in those patients young, below the age of 30 or around 30. So approved. The response after 3 months of imatinib is adequate because it's less than 10%, and we paid in terms of toxicity in the past for a sort of overswitching. And nowadays, after data generated particularly by MD Anderson Hospital and the German group, this case is at very low risk of progression, even continuing the same drug. So, in other terms, imatinib. And I would wait in this case for another 3 months to take eventually a decision to switch or not. This would be my policy looking at this data.
Thank you, sir.
Waiting. Yeah.
So, should we move? Next slide, sir. So
Can I
I think
ask a
we'll move to
question?
second case.
Yeah. Can I
So I
ask a
think
question?
let's open this discussion to the attendees, the delegates who are attending this.
Yeah.
Yes, yes, Dr. Starling, please go ahead.
Yes. See, the
Yeah.
basic problem in India is the cost of the asciminib. So where we can't use asciminib for majority of our patients. So still we are not using it in the front line. So hope you use it in the front line. So will the conventional BCR able tyrosine kinase inhibitors we are using since so long will work in the second line if there is a failure to asciminib? So what are our treatment options will be if the patient has failed an asciminib in the front line?
So Tony, can you take that? Like you've given a patient asciminib first line, then that either the patient doesn't respond, which is a very, very tiny chance, or if the patient does respond and after a few months or few years, there is molecular relapse, is there a scope for using a second generation TKI or a third generation TKI?
Yeah.
So,
Emma.
Gianantonio, we are waiting for you.
Yeah. No, yes, I'm thinking that it is a good question. But starting with a costly drug, no doubt, which is the drug better tolerated among all the others. So they're showing a very good quality of life. And there is no other drug in the past where patient takes the phase one, for example, after 7 years, still 50% of the patients were on asciminib. And there is no other experience where in the long term, with the second, third, or fourth line treatment, 50% of the patients are still on treatment. So it's effective and very well tolerated. In case of lack of tolerability, and Stein, you know well that the chance of having a lack of tolerability of asciminib, particularly in frontline, the ASK4 first trial shows this clearly. As Aman said, we have the opportunity to use a second generation TKI in case, for example, of emerging mutation. We have 2% emerging mutation with the asciminib frontline, or and in case of lack of tolerability or toxicity, for example, sometimes pancreatic toxicity with the asciminib. And the further choice will be probably directed versus bosutinib or dasatinib and not nilotinib. But I cannot see a huge problem from this point of view. As you underline, the cost is a problem, and so to deserve resources to those patients with, for example, an higher risk of many comorbidities, taking other drugs, and you know the most selective drug is asciminib, no doubt. So I'm not saying that the other drugs are completely out of duty, because I'm still using imatinib at least in 50%, 60% of newly diagnosed patients, and this is a wonderful new opportunity. And if I erase from my mind the issue of the cost of the drug, I'm sure I would be happy to use asciminib in most of my first line patients, newly diagnosed CML patients.
So thank you, Tony. There's another question on the chat box. The question is when to stop hydroxyurea, and can you start TKI together with the hydroxyurea, or you have to use them one by one? So I'll answer that quickly. Yes, you can use both the agents together. We normally use it when the presenting blood counts are very high, because the TKI acts a little slowly, hydroxyurea acts quickly. And when the counts get to around 20,000, then you can stop the hydroxyurea and continue the TKI. So we have to continue now. We have to move on. And I'm handing the proceedings back to Dr. Mipsang for his second case.
Thank you, sir. So with the second case, on 13 November 2024, we had a 18 years old male. He just went for a regular investigation and his count was pretty high, 186,000, probably 87,000. And that with the immature cells, hemoglobin and platelets were within normal. LDS was 1,195. So they did a PCR and then it was 44.681%. Karyotyping was like, it showed a like a translocation 922. Rest of all the reports were within a normal limit. Performance status was 1. So CML CP, sokal score 0.8, intermediate risk. So he was started on imatinib 400 mg daily. Is the TKI good to start, or should we have gone for a second generation TKI as NCCN guidelines has advised? So, Professor Rosti.
This is a very young patient, 18 years old, and to apply either sokal score or ELTS, any prognostic score, in some way it fails in very young, because very young patients, and here we have more than one large publication, one from Andy Anderson, the other one from the German group, and the other one of the Italian GMEMA group. Those patients below 30 have a more expanded disease, as it is the case of this patient, and a more pronounced trend to proceed with an accelerated and blast crisis. So they respond less brilliantly. Of course, the reason is that very young age in all risk calculation is a relevant demultiplicator of the final score. So we have an intermediate risk in this case, but because of the age, because you see spleen, leukocytes, etc., are very expanded. So in my policy, Mipsang get in Europe, the median age at diagnosis is around, of CML is around 60 years. And so those below 30 are 5%, no more, of the casuistic. I start in 100% of them with the second gen TKI frontline.
Thank you, sir. So next slide. So 2 weeks post imatinib, he complained of a severe backache and a bilateral thigh pain. The pain was so severe it was 10/10. He was in a hematological remission already, but we did a CK total that was 410 and constantly rising. So other LFT, RFT were normal. We just thought of this as a TKI-induced myositis. So pain did not relieve with the regular analgesics and a pregabalin. So we had to admit him, get him an MRI to rule out other spinal pathology. So imatinib was on hold, did a symptomatic treatment till his myositis was resolved. After the resolution of the symptoms, we rechallenged with the imatinib 200 mg. But 3 days after starting imatinib, he complained of the same problem. So imatinib was stopped and probably thought of changing to a new TKI. Next slide, sir. So, Professor Rosti, should we change the TKI? Or what should be the next choice? Should we consider a BCR-ABL kinase mutation before switching to a new TKI, just to get the exact idea of what TKI that we should be starting on him? Mm-hmm. Over to you, sir.
Yes, of course, after the challenge with the imatinib, whatever the reason, he had the same high level pain with imatinib. So change is mandatory. And in this case, the choice is you can throw the coin, because either the dasatinib, even 50 milligrams, or nilotinib are both good choices. He had otherwise a highly sensitive disease. So when you probably a mutational study before switching in this case is not totally mandatory, because he had more or less a normal blood counts after having a short period of imatinib. So change to dasatinib 50 milligram daily or nilotinib 300 BID.
Thank you, sir. Evan, sir, next slide, please. So continuing with the case, so no mutation analysis was done. So after second episode of our myositis was resolved, we started dasatinib 100 mg on the 5th January 2025. As I think dasatinib with the max foundation level indication, we cannot start a 50 mg right away. That is, I think that's what we did. So post 2 weeks of dasatinib, he complained of yellowish discoloration of the eyes, blurring vision, and floaters of the eyes, and itching sensation all over the body. His count was still good, but then there was a kind of a slight transaminitis. ALP was a little higher inside. So we involved a hepatologist, ophthalmologist. They suggest to hold a dasatinib with all multiple issues going on. So ophthalmologist finally found no specific cause for that, and hepatologists consider the ursodeoxycholic acid for 2 weeks. So after 2 weeks, LFT resolved and other symptoms resolved. So we started him on a dasatinib with a reduced dose 50 mg daily. Excellent. So over to you. How common is LFT derangement with a dasatinib, and what could be the pattern? We mean like cholestatic pattern or hepatic injury sort of things. So any guide to hold a dasatinib induced liver injury, because like this was a kind of a mild transaminitis, so we could have just gone with a reduced dose, but then with the multiple issues going on, we hold under dasatinib. So was that correct? What do you say?
Okay, Mipsang, you called this picture transaminitis. As many years ago, Brian Drucker, for the first time, used this term because it is not a liver hepatitis. Liver function usually normal, and is common to most TKI we are using, except asciminib probably. That around 30-40% more for bosutinib, but they have some LFT alteration. And in most occasions, they rechallenge waiting for a complete normalization of liver enzymes is successful, and the episode is no more evident. Otherwise, this patient has a particular picture different probably from the common and usual liver alteration under TKI. And in this case, probably dasatinib, which is the more, immunological disturbance TKI with respect to the others, may have a role. Nowadays, I can see this very young patient had two particular and tough adverse events. The first one with imatinib, with myositis, and this is the second one with dasatinib. So I, in this case, would be happy to re-challenge, probably at 50 milligram dose, because with dasatinib there is a relation with the dose and the incidence of so-called liver toxicity, and considering in this case to use asciminib if possible as third line, because apparently the off-target effect of the TKIs, at least imatinib and dasatinib, in this particular patient at a very high level of a very high prevalence. So using a much more selective drug like asciminib would be a choice. So liver normal, re-challenge with 50 milligram of dasatinib, and in case of failure, turn on to asciminib. This would be probably my plan.
Thank you, sir.
I would agree with a
slide.
re-challenge. I think that's not uncommon to see liver abnormalities. And I would also be curious with this particular patient, because he was experiencing pain, like was he taking acetaminophen or something else that could have been impacting the liver as well? Just a thought. But either way, I think re-challenge once things normalize is a very reasonable thing to do before moving on.
Yeah, I think I agree.
Thank you.
It's very, very rare to have like muscle toxicity with imatinib. I've never seen it in maybe more than 1,000 patients which we've given imatinib. But however, liver toxicity with dasatinib does happen, and the standard recommendation is as soon as the toxicity is down to grade 1 or less, then you restart and you restart at a lower level. So we have one question on the chat box. Maybe Dr. Kendra or Dr. Gianantonio would take this. Patient of CML CP, imatinib 400 milligrams started. Optimal response at 6 months, but persistent anemia. Nutritional deficiency ruled out. So the working diagnosis is imatinib-induced cytopenia. So how to proceed? Do a marrow aspiration biopsy to confirm hypocellularity, or to reduce imatinib dose, or to switch imatinib to dasatinib? What would you do, Tony, for a patient who's had a good molecular response, optimal response after 6 months of treatment, but has a pancytopenia and disabling anemia?
I understand that anemia was the only problem, so it's not a pancytopenia, but limited to anemia. And imatinib, from this point of view, at least in vitro, is promoting more this erythropoiesis than with respect to other drugs. So if the problem is only anemia, let's say between 9 and 10 grams, generally with macrocytosis, and the patient is highly sensitive because is already 0.6 after 6 months, my suggestion would be to reduce imatinib dose to 200 and following then the track of molecular response, and eventually to switch later on in case of loss of the molecular response. But only if the problem is only anemia, and asking to the colleague AB, he can answer eventually in chat to my question.
Thank you, Tony. I think we should move on over back to you, Dr. Mipsang.
Sir, I think
okay, I say
one of the slide.
Hemoglobin is 7.8, and is the only problem, because if not pancytopenia but only hemoglobin, but in this case it's quite relevant anemia, only anemia, and microcytosis. I guess probably the MCV, the mean corpuscular volume is over 100, probably, but I'm trying to I had cases like that with imatinib, and probably at this point with 7.8, having ruled out other cause of anemia like iron deficiency and so on, probably switching on site would be a better choice. And of course, a bone marrow, probably to a bone marrow aspiration to look particularly to erythropoiesis, because it's a problem with imatinib can be related. So looking at sign of this erythropoiesis and lack of terminal maturation of the red compartment.
Okay, I think we'll move on over to you, Dr. Mipsang.
Sir, can I have the previous slide? Okay, so continuing with the case, post 3 months of treatment, hardly 2 weeks on imatinib and 4 weeks on dasatinib. On 10th of February, we did a PCR for BCR-ABL, then it came out to be 4.351%. Next, sir. So how to explain the response with the interrupted TKI? Which TKI should we give a credit to? Professor Rosti.
Okay, no, this is a highly sensitive case, and after even 1 month of dasatinib in a patient treated for a couple of weeks with imatinib, is a very good response, a very sensitive disease. With TKI, should we give credit to? I would say probably to both, but but the big work was done by dasatinib, because 1 week of dasatinib, 100 milligram daily is sometimes very highly active. So, but okay, no, it's moving on well. This guy after a difficult start. Yeah.
Thank you, sir. So continue with the case. On 25th February, he visited us having a itching sensation over the body again, ALS discoloration of the sclera. Counts were still normal, but LFT shoot up, like total bilirubin 2.45, transaminitis again, alkaline phosphatase high. So again, we had to put a dasatinib on hold for another 2 weeks. Next, sir. So LFT resolved after that and restarted re-challenge with the dasatinib 50 again on 10th March 2025. Now the dose is tolerating well. Next slide, sir. So can we start a dasatinib 50 mg, which already I think answered for this type of patient? And I would just like to add, it is not there, but then 20 milligrams, sometimes they say like we can go lower, like 20 mg for this type of patients.
So Tony, you want to take that 20 milligrams dasatinib?
I generally prefer to start with 100 and then reduce the dose to 50 after. I mean, the idea that the patient is sensitive, but no doubt that MD Anderson produced very good data where 50 milligrams are. We like a randomized trial to demonstrate that. We have a propensity score from the MD Anderson, and they said shortly that results were the same with 50, with less chance of retrieving a pleural effusion. So, and you know, Hemant, that in the ELN and in the ELN recommendations, brand new that this is an OLET. But it cannot be suggested to give 50 milligrams to all. A good idea maybe to start 50 with dasatinib when the patient has a very expanded disease, and in this case, starting brutally with 100 milligram, you can retrieve a profound cytopenia, but is a particular. Otherwise, I prefer to start with 100 and then to optimize after 3 months or 4 months or whatever with 250. But it is my personal opinion then.
I typically would start at 100 as well, although I fully recognize the data with 50, and I know there are people who start everybody on 50. I guess my purpose for starting at 100 is just, you know, the bioavailability of dasatinib. The concentration is pretty different from one person to the next, even on the same dose, and so I'd rather just make sure that we're meeting those early milestones and getting a decent response. But if someone has side effects, I'm always very quick to dose reduce, particularly with dasatinib, because I do think the efficacy is still quite excellent at the lower doses.
Excellent. So I think that is exactly what I do also. I start with full dose, and if there is toxicity, then go to 50 very quickly. So Stalin, I think you're on stage now. We'll move to the second topic of discussion today,